All right, so we're about 1 minute after the hour, whatever hour that might be for you, where you are. I'd like to welcome everyone to an excellent presentation we're going to have today from the CKD Clinic Network. I'm Monica Bollier, the chair of the network, and I'm very excited today to introduce our two speakers. Their bios were attached, and I'm sure you were as amazed as I was. I'd like to introduce both Dr. Megan Elliott. Megan is a very well-trained researcher and nephrologist at the University of Calgary. And we'll just have people mute as we go. She actually studies patient engagement, person-centered care, and knowledge translation. And so we're very excited to have her today. And then reading Nancy's bio, it's nothing short of exceptional. She's a patient advisor that has generously given her time for many different projects in the kidney realm. And she is an OT, which is a wonderful background to have. And also, as you saw, a kidney patient that's touched all modalities of kidney care. So we are thrilled to have them both. In terms of the presentation today, we will have the presentation start. It looks like we have over 32 people from all over the country, which is amazing. And Megan and Nancy, just let us know if you want to stop for questions or do at the end, but people feel free to type into the chat and we'll be able to moderate questions either through the presentation or at the end. Over to you, Megan and Nancy.
Sure, thanks for the introduction and thanks for having us today. I'm really excited to be able to present to you together with Nancy. That was a great introduction. I don't really have much to add. Nancy, do you want to say anything before we jump in? Oh, you're muted still. Okay, I think you said no, you're muted. I'll just jump right in and get started then so you can go to the next slide. Neither of us has any disclosures. Next slide. So what we're going to be talking to you about today is around peer support, and specifically about peer support in the chronic kidney disease or non-dialysis population of patients with kidney disease. Not to say that peer support doesn't exist or it's not important at all stages of kidney disease, but for the purposes of this talk, we're going to try and focus things a bit more on the transitions through the kidney care clinics and on towards dialysis and decision-making in that regard. So the two big areas that we're going to try and cover today are firstly, why is peer support important? So what is it? What do we mean by peer support? What are the support needs of patients with kidney disease? And then secondly, how can individuals who have kidney disease with lived experience of kidney disease help support others along their own journeys with kidney disease. So I'm going to cover the first part of the talk that goes into some of the background around peer support and what it means and some of the literature around that. And then I've been doing a lot of work with Nancy around peer support, and she's going to present some findings of a study that we did together where she was a co-facilitator or a moderator for some of our focus groups. I do a lot of qualitative research, and it's a great way to capture patient experiences, and it's a great way to integrate patient perspectives as partners in research as well. Next slide. So, why am I interested in peer support? It's not that intuitive to take a leap from being a nephrologist into delving into patient experiences with care and support needs. But I think some of you on the call might have been involved with this project. A few years ago, I was involved in a priority setting project for research priorities in kidney disease. And as part of my master's work, I did a follow-up study on this, and I interviewed participants from this priority setting exercise. And this quote came from one of the participants, and it's really stuck with me over the years, and I use it in a number of talks and presentations I give, because I think it's really impactful, and it really shows the motivation behind a lot of what I do. So I'll just read it to you. Prior to joining this JLA or priority setting group, I really had not met any CKD person. It's quite an isolated personal space, you know? You wait in the hall to see the doctor, you go in and you meet your doctor, and then you leave the clinic and you're back to your home setting again. Rarely do you meet or interact with another CKD patient. And I don't know if this resonates with any of you, but as a clinician, I'm oftentimes very focused on the clinical issues and managing their blood pressure and patients' diabetes. And we kind of forget that they're a whole other person outside of that. And this patient was not on dialysis at the time, but since went on to do dialysis, and I think recently received a transplant. So after this project, I started noticing this topic come up again and again in kidney care clinics, clinical encounters, research settings, stakeholder settings. So I think it's an area that's really ripe for research and also looking into to try and support our patients in a better way. Next slide. So I wanted to frame this around a case. And so I'm just going to present this to you. It's a 60-year-old man, possibly a typical patient that we might see in our CKD clinics, stage G4A3 chronic kidney disease, meaning they have albuminuria and their GFR is, this person's is 18 mils per minute. They have diabetes, hypertension, gout, and osteoarthritis. They're at very high risk of kidney failure the next 2 years at 50%, and they're followed in a multidisciplinary chronic kidney disease clinic. Now, as I mentioned, as clinicians or myself, we might stop there and try and focus on their osteoarthritis, hypertension management. But when we take a step back and get a fuller picture of this patient, we learn that he's an older man who's divorced. He has 2 adult children, has no supports in the city or around him. He does some part-time work, is financially secure, lives alone, few hobbies, and doesn't know anyone else with CKD. So when we look at this aspect of the patient encounter, we might identify some gaps or areas where we could provide support other than simply addressing the medical need. Next slide. So why do we care about chronic kidney disease? I don't think I have to tell you, but we all are all very invested in kidney disease because number one, it's so common. It affects 1 in 10 Canadians. The proportion of people who have more advanced kidney disease in the advanced CKD clinics is closer to 1 in 30 or 1 in 50. But they have a high number of comorbidities. I think on average, the CKD patient has 4 or 5 comorbidities. They take upwards of 14 plus medications. And we know that they have poor health outcomes, including death, and result in high costs of the healthcare system, particularly as they approach and start dialysis. There's, again, another side to that coin. And when we look at it from the patient perspective, what's most important to the patients? Well, it's their quality of life. And we know that people living with CKD tend to have poor quality of life or lower quality of life than people without kidney disease. They have high rates of mental health problems, and they struggle with coping and self-management of their complex chronic disease. Next slide. So this graph shows the quality of life among people with chronic kidney disease. And this is a survey of about 500 people with CKD and some controls. And they found that among people at any stage of chronic kidney disease, their quality of life scores, and this is an SF36, are lower than people without kidney disease. And then as the kidney disease progresses, people with more advanced disease have worse quality of life than those with earlier stages. And quality of life is particularly low as people approach the need for dialysis. So as they're about to start dialysis. Next slide. And receiving dialysis is associated with even lower quality of life than pre-dialysis or non-dialysis chronic kidney disease. And in particular, in people who do dialysis in a facility, so facility-based dialysis. This is a figure that was from a paper that talked about potential strategies to improve quality of life for dialysis patients, but I think some of it applies to what we're talking about today. So what we can focus on, or what we help provide, or the provider treatment strategies in the top right, so focusing on improving their anemia, helping with mental health, their sleep and sexual dysfunction, things that can impact their quality of life. We may also try and move patients where we can towards other modalities that have better quality of life, like home dialysis or transplant. And then the bottom section is really the patient level or patient-directed strategies where we can try and enhance our supports and ultimately improve quality of life. And so the social support piece of this is what really relates to our talk today around trying to find ways to optimize social supports for people with here in dialysis, but also for non-dialysis chronic kidney disease patients. And next slide. This is a figure that outlines a workshop that we held in our kidney care clinic a couple of years ago. So this was a strategic planning meeting that we had that involved all the clinics, a number of clinic staff, as well as nephrologists, administrators, and patients. And what we did was establish the vision and mission of our clinic, which is to deliver collaborative patient-centered care to people with advanced chronic kidney disease through sustainable best practices. And one of our 3 strategic goals is actually to facilitate peer mentorship opportunities. So I show you this to show that it is a priority for our clinic in particular, as I imagine it is for a number of you across the country as well. Next slide. And this issue of enhancing supports and optimizing quality of life and care of CKD is also reflected as a priority for patients. So this is the priority setting exercise that I mentioned before that we did, I don't know, 5 years ago or so now. It was quite a while. But at that time, one of the top priorities identified for patients and stakeholders with chronic kidney disease was the develop strategies to enable patients to self-manage their CKD and comorbidities. And some of the work by Dr. Hemmelgarn and Dr. Donald in our program showed 3 big enablers or ways to support self-management. And that's either through providing or ensuring that they have adequate knowledge about diet, lifestyle, medications, finances, etc. And also ensuring that they have access to information, are able to share and translate information. The third big one was ensuring that patients have the supports that they need along their health journey to enable self-management. So this whole area of social supports, peer support, self-management are all interrelated, and it's meant to promote self-care, empowerment, and to really have people gain a sense of confidence and comfort with it, where they are in their kidney journey. Next slide. This figure came from a recent publication that was talking specifically about transition clinics. So the concept of helping people transition through their kidney disease trajectory. And so as it is with our clinic, and I'm sure with a number of your clinics as well, people enter the clinic once they meet a certain risk threshold for progression of chronic kidney disease. So for example, having a risk of kidney failure of greater than 10% within 2 years, according to the kidney failure risk equation. And so at that point, typically patients will enter our multidisciplinary kidney care setting. And at that point, we focus on patient education, monitoring, helping them transition through their journey, as well as prepare them for different types of dialysis and transplant availability. As the kidney disease progresses, at one point, we have to start making choices about which path patients are going to take. So whether it's a conservative care route or moving on to dialysis or transplant assessment. And as you can see, as people move through these clinics and through their course with kidney disease, their kidney function gets lower over time, but at the same time, their support needs increase. And in this picture, in this figure, most of the supports are concentrated towards the right-hand side. As people are approaching dialysis, we really try and provide as much as we can so that they can make informed, shared decisions. However, I would argue that as much support, I think, is needed earlier on, because patients are transitioning all the time, and it's a big adjustment to go from having normal kidneys, healthy kidneys, to all of a sudden hearing you have slightly lower kidney function, and then, oh no, my kidneys are getting worse. I think there's a role for support at every stage and not just focused towards the later stages. Next slide. So when we talk about support is a very broad term, and peer supports specifically, the aspects that these supports focus on are fourfold. There's informational support, so providing patients with information about their disease, lifestyle impacts, With peer support specifically, you can talk about experiential knowledge, so imparting your own experience and knowledge of having lived with kidney disease. The emotional support side of things focuses on empathy, providing an empathetic response to patients, a safe place for them to talk, and offering encouragement and reassurance. Appraisal support is more affirming their experience, so allowing them to compare their own experience with others who have gone through possibly the same thing or at a different stage in their own trajectory. It helps to affirm their own experience and identify with others. And then the last, instrumental support, it's not typically included as part of the peer support framework, but instrumental support, it refers to more concrete assistance with tasks. So helping with meal preparation or accompanying patients to appointments. All of those, the impacts of all of those are more inward looking and can relate to issues of gaining control or feelings of control over your condition, feeling empowered, understood, gaining a sense of normality. Next slide. But none of these supports are provided in isolation. They all occur within a broader social community that includes the patient themselves, their family and support, informal supports, healthcare team. And as we're arguing, it should probably include for a number of patients the option of connecting with others with lived experience, so that peer support piece. Next slide. So when we say peer support, and sorry, this is coming a bit late into the talk, but the definition of peer support is providing support for a person with a chronic condition from someone who has experiential knowledge of the same or similar condition. And it's really an umbrella term that can encompass a number of different types of supports, whether that's active listening, providing education, tutoring, peer mediation. But what we are focused on here, and it's often used synonymously with peer support, is the peer mentorship piece. And the peer mentorship is meant to refer to someone who is able to offer those 4 types of supports that or 3 or 4 types of supports that we mentioned before. Next slide. So we talk about peer support usually in the context of self-management, so as one piece of promoting self-management. But even looking in the broader context, peer support can really help with empowerment. And what we mean by that is increasing people's confidence to manage their disease and live their lives, helping them gain control over their life and gain knowledge and skills. And the outcomes of that are multiple. So it can have impacts on their health outcomes, their quality of life, as we had mentioned, self-management. What I really like from here is the thriving versus surviving concept. Some of you may have heard this before, but I really appreciate when patient partners talk about this. And it's not simply living with your disease, learning to live or cope with the struggles of your disease or condition, but it's going beyond that and thriving. So finding ways to not only survive, but actually excel and thrive in life and accomplish your goals. Next slide. So with peer support, who is a peer? So it's someone who has, as we mentioned, experiential knowledge of that condition. Typically, it's someone who shares common characteristics, although not necessarily. So by that, I mean a similar age range, potentially, or gender. Because peer mentor roles are typically volunteer, it has to be someone who's committed to the role of being a peer mentor and someone who's relatable, will listen, is empathetic. And the word peer actually comes from the Latin word par, which means equal. And so one of the key features of a peer support relationship is that it's non-hierarchical, meaning that the peer mentee and mentor are considered equal and should have that reciprocal sharing relationship. In the bottom asterisk, this was a paper, I believe, in peer mentorship in chronic disease, not specific to kidney disease, but there is some data to suggest that peer mentor volunteers are more likely to be female, white, educated, and from a higher socioeconomic background. Next slide. So peer support does not necessarily mean the same thing as socialization. Certainly, social aspects are an important part of peer support relationships, but it's not the only piece of it. A peer mentorship relationship should not be exclusively one of socialization or companionship. And really the key piece of the peer mentorship relationship is that it implies that one party is assisting another, providing those supports on top of the social pieces. Another key piece is that the peer mentors are trained and qualified to act in their roles. So that's also what distinguishes it from social aspects, is it's not just meeting up informally with someone on the street, but someone who is trained providing these encounters and providing these supports. And oftentimes in many programs, peer mentors undergo background checks, they're trained in communication skills and confidentiality, and they learn how to respond to patients' different concerns. And in particular, they are not typically supposed to be involved in providing medical advice or medical suggestions. It's really meant to be sharing their own experiences and lending a listening ear. And so knowing when to refer patients on to their physician or healthcare team when they do have medical concerns is another important piece. Next slide. So there are a number of different models of how peer support is delivered, and a number of permutations of all these items on the screen. So in terms of the format, how it's delivered, either in person, virtually, by phone. There can be one-on-one sessions or group sessions. It can happen, the timing can be earlier or later or throughout the disease course. Duration of contact can vary. Oftentimes, peer support will be integrated within a larger self-management or educational program. And the sessions can be either structured or informal and be facilitated or not. Next slide. In kidney disease specifically, so I know there's a lot of activity around peer support that's going on, but in the research or published literature, there's really not a whole lot to guide us and tell us what the best way or optimal way of doing these peer support programs is. This was a review article published a few years ago that reviewed, I think, only 6 published peer support programs in kidney disease, most of which were in the dialysis. Dialysis, I think one was maybe in transplant and one in chronic kidney disease. And what they did was categorize or list the different strengths and challenges with the different types of models of peer support. And as you can imagine, they all have their own strengths and weaknesses, right? People who are participating in a support group might really appreciate all the perspectives that different people bring. But on the other hand, they might be a bit more uncomfortable bringing up sensitive issues. Web-based platforms are highly convenient, and they may be the only feasible option in times like right now with a pandemic. But at the same time, some people struggle with electronics and accessing technology, and you might not get that real connection like you would meeting someone in person. All have strengths of strengthening relationships, normalizing the experience, and helping to reassure patients. But again, on the other side, all have certain challenges, particularly related to how willing people are to share their experiences in each type of setting. Next slide. This is a systematic review of quantitative studies that looked at peer support when delivered as part of a chronic disease management program. And of the 65 studies, none of them included kidney patients, okay? Most of them were other chronic disease settings. But despite that, the vast majority showed improvements on objective measures like blood pressure control and A1C when peer support was included as part of a management program. And also it showed improvement on quality of life and other standardized measures of symptom control. Next slide. This is a qualitative synthesis of peer support in chronic disease management, and it's similar to a systematic review, except with only qualitative studies. And what these authors found is that this is a conceptual model that they developed on the basis of their findings. And what they found was that isolation was a common trigger or impetus behind the peer support program. And both mentees and mentors identified benefits of connection, that feeling of connection, addressing that isolation and finding mutual meaning. Mentors, in addition, appreciated being able to share their experiential knowledge and derive satisfaction in helping others through their journeys. The long-term post-intervention or long-term impacts that they found related to peer support, again, relates to the finding of meaning, the empowerment that both sides took away from this, and a perceived change in knowledge and behavior as a consequence of the peer support relationship. Next slide. So as I mentioned, there's not a lot out there in the kidney disease literature. I'll just present a couple of studies here. This one is a randomized trial that looked at peer support when integrated as part of a more comprehensive self-management program. So this was a three-pronged program that included a health information course, monthly meetings with face-to-face meetings with the healthcare team, and a bi-weekly in-person peer support group. And this happened over the course of a year. And what they found is that the people who participated in this three-pronged program had lower rates or slower progression of their kidney disease. They had reduced hospitalization, but no difference in mortality or kidney failure. And unfortunately, they didn't report outcomes like quality of life or symptom control, which would also be really important things to look at when we're talking about the role of peer support for our patients. Next slide. This was a qualitative study that looked at, it interviewed patients, and this is non-dialysis CKD patients in the UK who had gone through one of their internally developed peer support programs. And they say that the peer support program developed organically in response to the needs of the patients and the providers in the clinic. So how this would happen is a CKD patient would be referred to a coordinating nurse through the program who would attach the patient with a mentor, a volunteer mentor. And this was supposed to be a short duration, 1 to 2 sessions, phone or in-person contact with very specific informational and emotional supports being provided. And the participants in this program really appreciated hearing the lived experience and the information that they got from the peer mentor. They saw the peer mentor as a role model, and it helped them visualize what their own trajectory and future could look like. And they appreciated the honest, encouraging, and supportive encounter. And as this quote says, one of the most positive things that this person found was that the mentor was just a regular guy. He was someone who was living a good life, and that was important to him. And so it helped the patient realize that he could get through this. Next slide. So while there's certainly value in peer support, there's also some challenges. Specifically, this paper looked at emotional and practical barriers to participating in peer support, namely the patient or participant receptivity or awareness of programs, a limited understanding of what peer support is, and that need for reciprocity. So the need to have a reciprocal relationship that's not one-sided. And this figure shows, offers some potential strategies to mitigate those barriers. So for example, by routinely offering it to all patients who come through your kidney disease clinic, having the patient have their choice of peer supporters or making attempts to match them based on certain characteristics or preferences, being flexible in how you offer these programs. So these are some possible strategies when considering developing your own peer support programs that you could take into consideration. Next slide. Okay, so I'll hand it over to Nancy now. Nancy's going to go through some of the work that we've been doing together. Thanks, Nancy.
Thanks, Megan. So I'm going to look at a summary of the data and what we learned from it. We've got some supportive quotes to go with that. and how peer support can help you in your own practice. And I think that's something that we often don't even think about. We talk about the importance, but we don't talk about how that relates to the medical staff. So next slide, please. All right, so this first quote supports the first theme that we came up with. But before we get there, let me give you some background about the study itself. Originally, it was designed that we were going to only focus on peer support. As we concluded the study, we discovered that we were actually able to go two ways, so peer support and the support environment. To start with, the objective for peer support was to explore the perceived role of peer mentorship in addressing the support needs of persons living with advanced CKD not receiving dialysis. So the focus was on patients and family with advanced CKD from 4 multidisciplinary kidney care clinics in Southern Alberta. The peer mentors from the Kidney Foundation of Canada with the Kidney Connect program. So we had 39 patients in 7 focus groups. There were 5 in Calgary, 1 in Lethbridge, 1 in Medicine Hat, and 4 of those focus groups were co-facilitated by patient advisors. The 13 telephone interviews included 6 peer mentors, 3 in Ontario and 3 in Calgary. They learned that the Kidney Foundation peer support programs really varied by region. So in Ontario, they had both a structured group and a phone contact, whereas Calgary only had phone contact. So the analysis of the information was by inductive and thematic analysis. And it was a qualitative study, all our data came from our patient direct conversations. So feeling heard and understood was our first theme. And this is really a situation where they wanted to hear from someone that could empathize and relate to what they were going through and to help them understand what they're experiencing, as well as that feeling that they were understood as to what their current experiences were. And that's what this first quote fits into. It was something on a personal note, when I facilitated the groups, I was very often the very first person they met that had CKD. And of course, I was actually on dialysis. And for many of them, they had been told that they only had about 5 years on dialysis and that life would be difficult. So meeting someone like myself that had been on 22 years of dialysis, that I'd been home for 18, and that I was facilitating this program, I was active and very involved, really changed their perspective on what they were anticipating and what they were up against in the future. So our next theme was understanding what's to come. So this is about navigating what's happening, what's potentially going to occur, talking to someone that's been there that can help them with their decision-making process and help them understand how the next steps are really going to affect their lives. Because as much as we can offer them all the information in the world about further steps, until you've lived it, it's really hard for people to relate to. It's really hard for them to hang it on anything because they really don't know what it's about. And the quote that supports this one is, this is from a focus group, hearing from probably more than one or sampling of people that have gone down this road before. I think that would be probably a biggest help for somebody that's starting off. I think more of a newbie in the game, what's down the road, what's the GPS. And I think that's true. I think it's important on all stages. And I do think that with this group, they were finding the same thing because the questions that I was getting and probably the direction it took having a patient was a little bit different than when we did not have a patient facilitator. The third heading was accepting and adapting to lives with CKD. So this is really the plethora of adjustments that occur when you have CKD, especially in the advanced stages as things are changing perhaps a little more rapidly or a little more dramatically, knowing that potentially dialysis is in their future. Having someone to talk to support them with those changes, to help them understand that it can be done, I think is one of the key things that goes with that. The quote was from one of the interviews. If you look at your disease, as something that is insurmountable, it's pretty easy to wallow in it. It's very easy to just say, poor me. But if you surround yourself with people that have, managed the minefield and come through it, you will come out, I think, with a more positive attitude at the end as well. And I think that's a really key statement, that so many of them are anticipating that their life is going to change so drastically that they won't recognize it, and that they don't know how they're going to survive it. And when you meet someone that's been through it, but also can help you with those adaptations, meaning that they have found their own way through their own experience, is often inspiring to help those people navigate through those next steps, help them to understand what they can do with themselves, but also to help build those connections with family and friends as well. All really important, because we also, as Megan had mentioned, that often when you're on the other side of the fence managing meds and blood pressures and all the details, that we miss out on the person that's actually living with it and actually experiencing it. And it's not that you don't want to know, it's not that you have truly forgotten, it's just that your focus is very different than the person living with it. And I found that, again, when people realized that they could still travel, that was a really big one, or that they could continue in previous activities, it made a really big difference. You could almost feel the room change as they learned that it was different than they thought it was going to be. And I think it's human nature to automatically think the most negative and the worst possibility. I do think there's some influence in that in terms of the way information is provided. But when you haven't met anybody with CKD, your imagination takes over. And it's not always the most positive and supportive imagination that you can have. The last one that we came up with for the patients and family was knowing you're not alone. And this actually ran as a common thread, sadly developing its own category of its own. And I think it's because, again, you haven't met anybody. Even when you go online, depending on who they choose to read and what they choose to listen to, a lot of it really is very negative, and a lot of it is very isolating. And it's often a blend between wanting knowledge and not knowing who to ask, or not knowing where to find support, but also being unsure as to whether you really deserve it or not, which I thought was a really interesting statement, that people would think that they don't deserve to be supported. And again, it comes back to experience, that for many people, just even finding one person made a really big difference in how they were coping with the next steps that came with CKD. And also realizing that they really truly weren't alone, and there was somebody that could help and listen to them. And the quote that I found for this one from a focus group was, it would be nice to be able to just pick up the phone and talk to somebody and say, this is how I'm feeling. This is what's going on. Is this supposed to be normal? This is actually, so I think you are right. That we need to be able to talk to somebody, whether you're a patient or a caregiver. And I thought that was very telling, that quite honestly, they don't know what's normal and what's not, because there's no reference points, there's nothing to hang it on. And I do believe that being alone, quite often, especially with a lot of negative information, really feeds into depression and anxiety, and does make it harder for them to manage. So simply knowing that there's someone they can talk to can make a huge difference in what's going on. And I can really attest to that over my not only 22 years on dialysis, but my 32 years as a patient, that the number of people that just needed to know that it was okay to be the way they were, and they had permission to be sad and depressed and frustrated, but they also had permission and encouragement to do well and live well with their disease. And that was partly, again, when I was on dialysis in center. In Red Deer, it was very, very small. And what I learned, and this is the discussion between in person or on phone or even online, is that often it was my role modeling. I was managing my diet, I was working, I was playing. And when I would walk into a room, whether it was my dialysis center, that people would look at me and go, well, you look really well. You look really healthy. What are you doing? And what we found was that on my dialysis time, gratefully, with my permission, the staff would fit me with people that had questions that I could answer. And they saw a huge change in the whole run group, that people were managing their diet better, their blood pressure was better, they sounded better, they acted better. And that was just by observation. I didn't talk to everybody. And I think that's a really important thing to be sharing. So next slide, please. So now we take it to the supportive environment. And this is, so the objective is similar, to explore the support environment of adults living with advanced CKD, not receiving dialysis, to identify support needs within the support environment. So we were taking it more specifically as how we can support them from the medical side. So you'll notice that every one of these deals with balancing, which makes sense because you have the dubious honor of trying to figure out when is the right time to give them the information and how much, and how to, and I'll go through these one at a time. I think one of the things that we miss the very most, at least from my experience, is that instead of asking the patient what they need or how they can help, we just make assumptions, that we sort of try and guess that we're going to get it right, but we don't know because we haven't asked. And one of the questions I very often ask, especially when I was in the clinic, is as I'm offering information or offering lifestyle changes, I would ask them, first of all, does any of this make sense? And you might get that blank stare because no, it's just so much information, it's not. And is it doable? And that will give you a really clear message as to where they're standing at that point. If they're saying to you, I can't do this, this is crazy, this is a good time to be saying, well, it's important to remember that it doesn't have to happen all at once, and that we do things in small steps and we can support you through this. So when we look at balancing information timed with the readiness, this is when we're trying to decide how much and when. And I find for many people that we need to plant that seed. So the idea is they may not be entirely ready for it yet. So you may not get full understanding and full changes and compliance, as it were, but you will get people thinking about it. And I think that's a really important graduated adjustment to the changes that are going to occur. So looking at having information early, one of the key features with this as well was reliability of information. So many times people would say, I'm getting, and this is from our groups, getting similar information but different. So it wasn't consistent across the board, and it wasn't something that they could readily slot into the right place because it wasn't connecting for them. So that's something that's really important, is making sure that as a team, you're not letting some of your own biases slip in, or that if you are, you're explaining yourself, that you're talking as a team in terms of what are you sharing with people, what are they knowing, how are they responding, how can we change it, does it need to be tailored more specifically to them? And it might, looking at language and culture and education, and indeed readiness to move on. Really important things to be thinking about. And this one I did have a problem finding a quote for, so I decided not to put one in. So our next one is balancing autonomy with support needs. And the quote that I picked that goes with this, there's nothing worse than somebody telling you what to do without asking the right questions. And so again, that ties in, they all tie together, so none of these are completely separated. So this is about actually feeling supported through the decision making, which means that it probably won't happen in 1 or 2 sessions. And they may need more support earlier on or later on. It depends on sort of how things are going and where they find they fit. And this is where the peer supporter is so valuable, that if you think about it, think about an experience that you might have had that you were expected to make a decision right away. And I can tell you, I was diagnosed as a crash start, and I had to make my decisions in 3 days. And all I had was a kidney foundation binder to do it with. So that was really hard. I literally had no concept whatsoever. And I also learned that you couldn't prepare emotionally for the changes that were occurring. And therefore, I think if I'd had a patient to talk to, I would have maybe made a different decision, or at least been more secure in the decision I made, because I had some idea what I was getting into. And often that's the big question mark they have, is that they need more support in that decision making. They need a way to hang their decision on a concrete experience and being able to integrate your care into that decision making. And I really think that a lot of this comes to listening to the patient. I mean, really listening. So that means You're not thinking about your next dance. You're not thinking about what's for supper. You're really hearing what they're saying to you right now. And I do think that that alone makes a really big difference in providing that support, but it also does support them in their personal decision making at the same time. So moving on to stability and flexibility. So again, people are going to be at different points in not only in their journey, but in their emotional adaptation and their emotional adjustment to what's going on. And I think this is where that means you might be going back and forth, that you might find that they come in and they're just frustrated and confused and they can't quite figure out what's going on, and they need permission to experience that, and they need permission to be supported as they find their way through that journey. So this is the challenge that comes with that autonomy. The next one is the need for, that is stability and flexibility. And what I really mean by that is that, again, consistent information, strong support with the ability to meet them where they are right at that time. And it can be anywhere down the line. The other thing to be aware of is that, and we don't, even though we integrate family very often into things, we don't often address them. That we listen to the patient, they're our focus, when in reality that patient is really worried about their spouse or partner, and they don't know how to support them, and they don't know how to help, and they don't know who to ask. And so it might mean that you may actually be saying to the support person, not how is the patient doing, how is that person doing, and what do they need? And it may not be much, but when the patient knows their partner supported, things are quite different, because they do worry about their partner and they really don't know what to do. They feel guilty, they feel like they're burdening them. And when the partner's not doing well, they often aren't doing well themselves. So that's something to consider. The last one is balancing expectations with the reality of living with kidney disease. The quote that I picked was from a focus group, and I could see if something happened like that, well, then you have to change your lifestyle, but I don't want to change it. So think about those early days. It's not a surprise. People don't want to change, partly because you're looking at loss, you're looking at what's happening next. Will I still be of value? How do I fit into the system? And how are we as a family going to get through this? And sometimes you'll meet, and sometimes expectations is actually denial. So you'll have patients that won't do anything to change because they're sort of pretending it doesn't exist, even though the more you deny it, the more your disease takes over. But at that point in their coping, that's where they're at. And this is where I think that peer support is just so valuable, is that it can support the medical staff as they provide information and support. But it also helps the patient and family understand how they can incorporate the changes that CKD brings into their life, and how they can continue and have a quality life and meet at least some of those expectations that they have. And some of them include, on a number of the web pages I'm on, there's people that are still competitive cyclists and competitive athletes. And then I get other ones coming on that say, well, should I quit? Should I stop doing this? Which is a really interesting question, because again, they really don't understand what's coming. So I think it's important not only for you to help them balance their expectations with the reality, but I think one of the key things is that that they can often combine the two and have a very successful outcome, and they can thrive on dialysis. Or even, like some of them don't actually get to the dialysis stage. So going back to the fact that even with advanced CKD or through the whole journey of CKD, that we can incorporate some or maybe all of those expectations with the reality, or perhaps we're going to need some changes, but how? Coming as an OT, that's what I did, was how do I actually do that? How do I balance the two of those out? Next slide, please. Okay, so this takes it back to you as medical staff. And I understand that, you know, we'd like to include peer support, and I'm a huge fan of that. But how is that going to help you as a medical person in every level, whether you're a social worker, whether you're a nurse or a doctor, any members of the multidisciplinary team will actually benefit from all of this. And I know that may not seem really obvious at first. I can really only explain it from my opportunity as a peer supporter, both formal and informal. and also the peer support that I got as a new patient, and remembering that I was a crash start, so I had so little to go on anyway. The good news is I had no negative input, but I also had no experience to hang anything on as well. So firstly, that provision of a lived perspective really does help them balance the positive and the negative, meaning that the positive is usually pretty easy to manage, but what do you do when you're having a really crummy day or things are really a problem? How do I cope with that? How do I manage with that? Can I, is often a question, can I do this? And how can I continue? Because often people get burned out. And when you have a peer supporter that can support you through that, it can make a huge, huge difference for them. And then we look at decision making, and really and truly it does give them confidence in the decision that they're making for themselves and their family at that time, which gives them hope for their future as well. And it's a combination of knowing that it can be done, but also knowing that there's someone they can talk to that understands where they are, that they can really empathize with. I think, and you've likely seen this one, and this is why I picked the picture behind it, is to clear that cloud of confusion between information and experience. And often information is very clinical based because it doesn't talk about the bad things that can happen directly, but it doesn't talk about the fact that things can be coped with and that life can go on. And I do think this is a really big one for many people, is that the lived experience brings for them the understanding of what they can do to support themselves. And when that happens, I think you'll see, again, more confidence. You'll see maybe, actually, this fits with the next one, is better questions. So if you think about your appointments, either one that you've had yourself recently or an appointment, the patient, and think about the fact that we usually end up our sessions with, so do you have any questions? And probably 9 times out of 10, either they look kind of glazed and a bit dazed, and they'll be, no, I don't have any questions. And it's because they haven't had time to think about it. They haven't had a time to let their brain mull over what's going on. And often they're feeling a little bit overwhelmed and maybe a bit intimidated. Not that your clinic is intimidating, but for particularly for people that don't really work in the healthcare system, medical appointments are really intimidating. That they often feel that they don't know anything and that only you can answer those questions, because including dialysis, there's people that'll tell you that they thought that was a decision that the medical people had to make, that it wasn't theirs, that was somebody else had to do that. And so often they need time to think through the information that they're getting, and perhaps being given not just an opportunity to call back, because I can guarantee you they probably won't, but if you happen to be their nurse or their care manager, it might be worth that quick call a week or so later that says, just checking in to see how you're doing. You know, any questions from last appointment, anything you'd like to know? They'll probably talk to you then. They probably won't call you themselves. And that's true with peer support as well. My phone number's all over the place and I have yet to have a single person phone me because they don't know what to ask. They don't know me from a hole in the ground. And they really don't know what to do with peer support when they've never had it before. The last one is about the light at the end of the tunnel. I think the really key here is that there is a light at the end of the tunnel. For many of them, they don't think there is. They think their life is over. They think they're done. And when you have someone to support you through those next journeys, it gives you an amazing strength that you didn't have before. And I think you'll see that in many of your patients as well, that they just sound and feel different, probably more like themselves that you might not have met yet. It's really important and it makes a huge difference. We used to find that in my clinic that, and I had a specialty in hand, so I'm dealing with traumatic, life-changing injuries. And when the patients would wait together to see us, very often you could see the light bulb come on. You could see them start to, again, come back to themselves because they discovered there was life after their injury. And I found that so important, and it was something I couldn't offer them. We couldn't set them up for peer support, but we only had 3 chairs, but it worked like magic. It made a really big difference for us. All right, next slide, please.
Nancy, I wonder if we could just advance. There's only 5 minutes left or so.
We'll skip this.
Maybe just advance to the last slide and we can take a couple of questions.
Sorry about that.
Sorry, there's just a couple other slides. they'll be in the handout or the PDF that Selena will circulate. But if you just go to the last one. Yeah, so we can wrap up here. And thank you all for coming to this talk today and listening to our to what we have to say. If you have questions, you're welcome to type them into the box or contact us directly by email. We're happy to respond that way. Nancy and I are doing a survey now. So we've talked about the patient and family angle, but we're really interested in learning what other Canadian kidney care programs are doing in terms of peer support, and what your thoughts are about peer support and how it's being integrated or not into your clinics. So we would really appreciate it if you would complete the short survey. You can click or enter the link or scan the QR code. And this will also go out in the follow-up email from Selena. So thank you very much. Take care.
And thanks to you, Nancy and Megan. That was fantastic and really meaningful. And I think one thing that resonated for me was when you said my number's plastered all over the place, but people don't call. And I think that is maybe something that can be explored in your survey, and something that we've definitely found, I know in BC when we've tried initiatives. Mo, I think, has typed in very similar comments in the stream. They're uncomfortable reaching out to strangers. I think that would be really something that hopefully the evaluations will help us explore. Any last minute questions that anyone wants to highlight today? I think we have time for a couple. All right, well, we have some hand clapping and I think some enthusiasm to complete the survey. There will be an evaluation as well, so I encourage you to fill it out. And in terms of our next session, we've been having a lot of interest, as I'm sure you would attest, in sharing our experiences on virtual care in KCC clinics around the country. So if you have a speaker or a member of your team that would like to be involved in this presentation, we're looking at one, I think in October, hopefully on the 15th, and then November on the 19th, but we'll send something out. But we really want to nationally share our experiences with respect to how we've been doing with virtual health, and try to put together some best practices as a country with respect to how we support our CKD patients. And so with that, everyone, have a great morning or afternoon. Take care.